Welcome everybody who's joining us today. Very excited to share our findings from the Strengths and Needs Profiles project, which has been running for the last 12 months at Autistica. So this is the outline of what we're actually covering today. To start off with, we have a brief explanation of who Autistica is and why we're doing research into strengths and needs assessments. Then I'll give you a quick description of why we're using the specific strengths and needs assessment that we've chosen, which is the ICF Toolkit, and a little bit about it. Then it's a bit more information about the study itself. So what we did, how we did it, and who took part. And then the findings. So a summary of what we found out. Then what we're going to do next. And finally, we are then going to talk about, answer any questions that people might have about the project. So I'll now hand back over to Amanda to introduce the next slide, which is a description about Autistica and why we're doing what we're doing.
Thanks very much, Harriet. Welcome, everybody. We're really glad that you could join us for the session today. I'm Amanda Rustoff. I'm Director of Research at Autistica. Autistica is the UK's leading autism research and campaigning charity, and we use research to create breakthroughs that enable happier, healthier and longer lives for every autistic person. We know that too many autistic people and families are left without the support that they need, and our vision and our mission is to create a world that enables every autistic person to live a rewarding and fulfilling life and happy, healthy, long lives. We know that from so many people that we've worked with over the last 20 or 30 years, that autistic people often and their families are struggling to find the resources that they need, both through the diagnostic pathway, but also post-diagnosis. And we really wanted to change that as one of the core goals of our research that we work on, and one of our 2030 goals, to be able to open up support along the way. So we were delighted to partner with Professor Sven Bolter and colleagues at the Karolinska Institute in Sweden on this ICF Toolkit project, to be able to look at ways of enabling and opening up access to support for the millions of autistic people in the UK. So I'm going to hand back to Harriet to explain a little bit more about the project and how we came to looking at delivering this piece of work, and how we can take the insights from this project to be able to shape what we do going forward.
Thanks, Amanda. So this is a little bit about why we're doing this project specifically. As Amanda mentioned, people's strengths and needs vary over time, and everybody who is autistic has very different strengths and needs, and that will look different for every individual and over a person's lifespan as well. The support and strengths will also be affected by the environment and daily life, where things can be supportive and empowering or disabling. And for some people, a diagnosis of autism is just the start of seeking this personalised support. And unfortunately, in England at the moment, that takes a significant amount of time. Too many autistic people sit on diagnosis waiting lists for years before support opens up, and too many reach crisis point before getting any sort of support at all. The most recent figures from NHS Digital show that the number of people on waiting lists has more than doubled since 2021. And almost 90% of people are waiting more than 3 months for an initial appointment. And many more are waiting more than 3 years. Those needs remain unmet during this time. So to get the best support, people who support the autistic community and members of the community themselves need to be able to understand individual strengths and needs and how these can change over time, regardless of diagnostic status. And a strengths and needs assessment, the ICF Toolkit, is a possible solution to this problem, which is why Autistica has brought together a consortium of research partners to investigate this, including the Karolinska Institute, as Amanda mentioned, and the NHS. And our 12-month study explored whether a strengths and needs assessment can help support autistic people and people with ADHD in education, employment and healthcare contexts, and find out what we need to know to actually use this in England. So I'm going to talk to you a little bit now about the ICF Toolkit itself, the specific strengths and needs assessment tool that we used in this project. So the ICF Toolkit is based on the ICF framework, and ICF stands for the International Classification of Functioning Disability and Health. It's a framework which was written by the World Health Organization from 2001, which describes and measures health and ability, as well as disability, on an individual and population level. And Professor Sven Bolter and his colleagues at Karolinska took the sections of the framework that relate to autism and ADHD and created an online questionnaire. The answers to the questions are filled in either by an individual themselves in a self-report format, or an informant, somebody who knows them well, who fills it in on their behalf. And the answers to these questions are then used to generate a personalised strengths and needs profile. The ICF Toolkit has 3 sections. The first one is body functions, and in this section, questions are asked to assess the person's abilities and characteristics. So what somebody is able to do and what they're like as a person. So some examples of topic that are included in this are sleep, memory, speech, and sensory processing, as you can see in the first screenshot example that's come up here. The second section is activities and participation. And these questions ask about what a person actually does and to what extent they participate in society. So that includes topics such as demands and changes, like how people manage changes to their routines, self-care, use of transport, activities and gaming, and engagement with community life, as seen in this second screenshot. The last section is about environmental factors, and this is the different aspects of an individual's environment that can help or hinder their everyday functioning. So this includes the impact of support and relationships from different key people in a person's life, the impact of assistive products and technology, medicines, and the impact of light and sound conditions, as you can see in the third screenshot example. So it covers a range of personal and environmental factors that can contribute to a person's functioning in day-to-day life. Ratings for each of the questions are given, and there's also a comment box to add explanations, clarifications, and provide more detailed answers. All of the questions are optional to answer, and you can also mark a question as unknown or not applicable if you're not entirely sure. So the idea is that people fill in this with the biggest level of detail that they are happy and able to share, and a personalised strengths and needs profile is generated from these answers. For the Strengths and Needs project itself, then, we were taking 12 months to try and answer 3 main questions about these 3 settings within England: education, employment, and healthcare, specifically adults who are on the waiting list for a diagnosis. The first one we wanted to answer is there actually a need for a strengths and needs assessment? It's all very well us saying, oh, this could be a great thing to use, but we wanted to see if there was actually appetite for something like this in England at the moment. Secondly, we wanted to identify what the actual benefits would be of using the ICF toolkit specifically, as opposed to other things and practices that are available out there. And lastly, with any sort of new introduction, there are going to be changes and challenges that need to be overcome. So we wanted to particularly identify what the challenges would be of using the ICF toolkit in England. And to do this, we asked a whole variety of people, more details on them in a second, for their views about the toolkit and the personalised profiles that were produced. So to start with, we ran a series of online workshops and online surveys where we were asking autistic and ADHD people and professionals in each of the 3 contexts to share their views about the toolkit, to see whether they thought there was a need for it and to see whether they thought it had potential to be used in England. And these were run as a series of workshops between summer and December last year. This year, we asked autistic and ADHD people to fill in the toolkit, fill in the questions itself, answer questions about the process of filling that in, and also to answer questions about the strengths and needs profile that's produced, whether they thought it was useful, what they thought could be improved about it, and what they liked and disliked. We also asked a series of professionals who work with autistic people and or people with ADHD to look at these strengths and needs profiles that were generated and answer questions about it. For example, whether it would be useful for them to use in their current practice, whether it was better than things that are in their current practice, and also just to find out generally what their concerns were about it and what they thought some of the benefits might be. We asked a whole range of stakeholders. I'm not going to go through all of these, but this is just to give you an idea of the breadth of people that we managed to speak to. We were looking at professionals and community members across all three contexts of education, employment, and healthcare, specifically looking at diagnostic waiting lists. And we wanted to get as much information as possible to map out the real benefits of this and to work out how this would work and be implemented within England. So we asked a variety of different people at various levels of seniority who would be involved at every single stage of the implementation process to find out what their views were. And this is what we found out. So when we spoke to everybody, everybody told us in generally, and I am summarizing because obviously there was a huge amount of information from this, but what was flagged up specifically across all three contexts is that people wanted and felt there was a need for support strategies to focus on strengths, not just on support needs. Support needs are very important to identify, but it's also very much needed to focus on the positive aspects and to focus on people's abilities as well as where they might need additional support. So this was something that came out across all three contexts. There's a real need to focus on strengths. There's also a need for that support to be very personalised to an individual. Some support that is out there at the moment can be quite generic, and as a result, and it's not necessarily terribly relevant to individuals and their circumstances. And again, this was things that came back from the wide variety of community members and professionals, that having personalised information about somebody makes it much, much easier to then provide and suggest more relevant support. What was also incredibly important was finding something that can be used in multiple different contexts and across someone's lifespan. We heard a lot of information from various people, especially from parents, talking about the journeys that their children were taking, where they were having an assessment that was being done at the GP, and then something that was being done by speech and language therapists, and then something else which was being done by a nutritionist. And there was a lot of kind of very siloed support that was going on, where you're referred to a new team and it's a whole new discussion and a whole new set of questions to answer. It was felt it was very, very important that anything that is going to be introduced needs to be able to be used across multiple different contexts, especially when you're looking at the differences in somebody's ability to function across those different contexts. A lot of people, for example, may struggle at work but be quite happy at home. So it's also able to identify more specifically where those support needs might need to be put in place and how. And also across somebody's lifespan. You know, children who are flagged up at school and referred to for an autism diagnosis grow into teenagers who are autistic, who grow into autistic adults, who grow into the autistic elderly. And people's strengths and needs will change over time. So there was a need for this not to be a one and done kind of approach, but something that would kind of evolve and would be a working document over time to help best reflect an individual's current levels of strengths and support needs. And finally, quite a lot of people were interested in something which has a strong evidence base behind it. We had some really excellent examples of local and very specific practice, which had been kind of created on a bespoke level. Unfortunately, there is not an evidence base behind these things. They've been created through need, and being able to generalize them across multiple different contexts is not necessarily possible. It also, in terms of future safeguarding, it's much easier to invest in something where you know that there is an evidence base that something works and there are measurable outcomes to demonstrate that this is having a positive impact. A lot of the really good practice that we heard about, as well as being very local, was not able to be evidence-based in this same way. And there was a call from commissioners especially who wanted to see that there's a strong evidence base behind whatever is being suggested. The ICF toolkit has the potential to fulfill all of these criteria. Strengths are explicitly asked about, as well as support needs in the questions. It provides incredibly personalised information about the individual because it's filled in by the individual themselves and by people who know them really well. It can also be filled in by several different informants, so you can use it across multiple different contexts. So somebody who can fill it in themselves, somebody who knows them well can fill it in, an employer can fill it in, somebody who works in education can fill it on their behalf, and it can be used across somebody's lifespan because there are different questions for different age categories. And we already know as well that there is a strong evidence base behind it. Not only is it developed from a framework developed by the World Health Organization, but there already is a growing research base of the ICF toolkit in use that suggests that this can really make an impact for people. So it was really positive to find out that the ICF toolkit specifically has the potential to fulfill everything that people are asking for. Whilst we're not promising the world, though, there are obviously some other benefits that were brought up. And here are some of the benefits that people identified specifically. One of them was the explicit focus on an individual's strengths and the personalised information. This is very similar to what we talked about before. Another real benefit of this is that it can be used with or without a diagnosis. So we were interested to see, for somebody who is waiting for a diagnosis, is this still relevant, meaningful and useful? And for it to operate in England, it had to work alongside and be complementary to diagnostic pathways without being dependent on them. And people's feelings were very much that this can be used with or without a diagnosis. When talking about using it across multiple contexts, it was really good that it provides a shared language to discuss an individual's support needs. So whether it's a GP or a learning support assistant or a parent, there's a bit of terminology in there, but not enough that that it can't be translated across several different contexts. And that was felt to be a real benefit for supporting that kind of joined up approach to support. It also shows how support needs differ across different settings and how the environment specifically can make a big impact on how somebody is able to really let their strengths shine, or where some additional support might be needed to adjust for somebody's particular support needs. Community members were also really happy that it provides an opportunity for self-report for adults. There's very much a whole thing which we are very much part of, which is the idea of nothing about us without us. And co-production and involvement of the autistic community is crucial to all the research that we carry out. The fact that this has the opportunity for self-report in there was seen as a real benefit from our community members especially, and also from the practitioners we spoke to, who wanted to know, well, actually, tell me about yourself. And this is an ideal opportunity to do that. In addition, though, one of the things people picked up is that actually, well, what happens if you're not necessarily aware of what you can and can't do? And actually, the idea for information to be reported from a number of different people was also felt to be really helpful. So if somebody, is not necessarily aware of what their strengths are, you can have somebody who knows them well providing that information, so you get a really holistic overview and lots of multiple perspectives of an individual to start those discussions about, okay, well, this is what you're really good at, but this is what you might need some additional support with. And lastly, it can be repeated over time to show how strengths and needs develop and change. It's not a one and done type implementation. So it provides a snapshot or a photo. And the idea is that these can be built up over time. Also, as a way of measuring impact, one of the ways that we're looking to identify strengths and support needs is you can look back and go, oh, well, at this point, this was something you need support with. This is the strategy that we put in place. How is that improved? Is this working? Do we need to look at something different? And the idea that it could be repeated over time was felt to be a real benefit. There are also some things that can be improved. As with anything, if we're going to present something which is going to be used across multiple contexts, it's not going to be bespoke for anything. And one of the great things about being involved with the development of this with the Karolinska Institute is that it's part of our development that we can go back and kind of think about what other things could make this even more useful and meaningful. One of the things that people talked about was some additional content. You know, it's come from the World Health Organization framework, but some suggestions were included that there actually you could ask about a few different things in there to make it more meaningful and specific. So more details about some of these topics in particular. So nonverbal communication, special interests, masking and camouflaging, and working memory were just a few of the things that people felt it would be interesting to have in there to help. Then there were some additional features which people were interested in having. So being able to filter answers to further personalize the profiles and control what information is shared. This was something that came up as part of the employment work stream specifically, where people were like, well, this is great. And this is a lot of personalized information about me, but I don't know if I'd want to necessarily share everything about this with my employer. So having the opportunity for creating a more kind of structured way in which information is shared was something that was felt to be, you know, would be helpful to have in future versions. And lastly, some additional guidance. So developing training schemes and frameworks was something that people were concerned about generally. They're going, this is a really great thing, but is this going to be used consistently? And one of the ways in which you can help support that is to have that additional guidance to ensure that that baseline of how this is used in terms of its efficacy is maintained from the start. And lastly, there are always going to be challenges, and it was really useful to be able to map those as part of this study. So one of them was about the amount of time that it takes to complete. With any kind of information that you are providing a lot of detail about, there is a time cost to that. And there is always going to be a trade-off about the level of detail you provide and the amount of time it takes to provide that detail. Now, any kind of assessment is going to take time, but it's worth flagging that this again came up for the ICF toolkit, that the amount of time it takes to complete is, you know, about an hour to 2 hours, depending on how much detail you fill it in. And it's something that people were concerned about. Along with time, the actual fiscal kind of concerns about how much it would cost. How much is it going to cost to fill it in? How much is it going to cost to license? How much is it going to cost to have the software to have this, to actually implement this as part of our systems? These are all absolutely valid questions, especially where funding is, you know, staying the same or being reduced year on year within local authorities and within ICBs. So these again are all valid concerns, which we weren't particularly surprised came up. And then also the knowledge it takes to develop effective support from the personalised information. At the moment, you get a personalised profile, but the variability of individuals' knowledge and training and how you actually build personalised support and effective support from those profiles was felt it could be quite inconsistent. And again, that was a concern that people had, like the people who are able to do this, who've got really in-depth knowledge, would be able to do a much better job than people who didn't have that kind of specific knowledge. So these are all challenges that were not particularly surprising to come up, but that were identified as part of this. What was also really nice, though, is that there were some solutions to these challenges that were brought up by the people that we spoke to that can be explored with future research. So the first one would be identifying where it saves time as part of referral pathways, so that the time to fill it in is actually offset by the time that is saved later. Similarly, identifying where this can save money will allow to offset the cost that it would take to implement this. And finally, developing those standard guidance and frameworks to ensure consistent use means that where this is used across multiple different contexts and throughout England, there is going to be a consistent way in which it is used. So this is basically what we're looking to do next. We're seeking funding now to run bigger feasibility trials to test these profiles in each of the 3 contexts we talked about. So in education, again, for adult waiting lists and employment as well. We're also currently writing up our findings into a formal report, which will be published very shortly on our website. So stay tuned for that within the next couple of weeks. That's a much longer term report if you want more detail on that, but that will be also coming out soon. We're also going to write up our findings into a journal article so that we can share it again with the academic community to make sure that they are aware of what we found out. And we're also working with our advisory groups from the project to make sure that what we found out are shared with the community in a meaningful and impactful way. It's not just necessarily a case of, oh, here's a webinar and here's a report. We're making sure that this information is actually shared with the people to which it's going to matter most. So that's what we're looking to do next. Now it's time for the Q&A. So if you have any questions, I know people have posted some in the box already, but if so, please do continue to add them to the Q&A chat so that we can continue to answer them. Thank you.
Thanks very much, Harriet, and thank you very much, everybody, for your questions coming through. And Professor Sven Bolter, who's very kindly joined us for this session today, who's already been answering some of the questions coming through. I wondered, Sven, if I could invite you just to set the context for the ICF toolkit as it exists at the moment, as purely being used in a research context right now, rather than being a publicly implemented toolkit in clinical settings.
Yeah, thank you everyone for being here. It's great. It's almost 100 people. I'm very happy about the interest and that people share my enthusiasm. So there are kind of two reasons for this being a research tool at the moment. The first is that we are really trying since now about 10 years to make this a very kind of rigorous process and trying to make this the translation of the ICF to the autism field and into services and research as rigorous as possible, so that once we have something that people really kind of like it and think it's a valuable tool to use and no one gets upset, so we want really that the idea of going from a diagnose-based more to a kind of functioning-based assessment, that this really kind of lands well in services and among autistic people. So we're taking it kind of slow and we're taking it as research-based as possible. And for this, we are doing both feasibility studies and trying things out in different settings with different groups in different countries. And we are always using the Swedish version as the version that we are kind of where the develop has been where we have come the longest way. And at the moment, we are doing a huge standardization study in Sweden, trying to collect data from 20,000 people, 10,000 self-reports and 10,000 informant reports, to also get some kind of background data that we can do good, that we have what we call for norms data that we can compare with, to also make a good estimation of individual functioning. So that's one thing. And the other thing is that there are also intellectual property rights involved, and the university has ideas and there's things about IP protection, because it's quite huge, and it's quite huge platform, and there's a lot of costs associated with everything that we're doing, and for making this a sustainable effort that we can also later on be able to circulate kind of, hopefully, kind of in many countries. It needs to have some also economical security, and this is probably the best way to do it, is some form of commercialization. And there's a lot of things that need to be cleared before, and in addition, maybe also there's a need formally that the whole system is developed to be a medical device. There are kind of international and European and also kind of UK kind of regulatory demands that we need to take care of. So all of this makes it that it's going slow, but also very kind of robust. But I think we have come a long way, and of course the goal is that we make it available as fast as possible, and hopefully that authorities will acquire licenses to make it freely available in their countries. I hope that answers the questions.
Thanks very much, Sven. I'm going to come to a question that that came in one of the early ones. Is the questionnaire still available? This person asking the question said they received a diagnosis 2 years ago but didn't know about the research. So just to clarify, so this part of the research that Harriet's just presented insights about is not really a continuation of the work that Sven's been doing, but it's to try and understand in the UK how useful this toolkit might be for education, for adult wait lists, and for people who are either looking for work or employed, and who might benefit from adjustments for tailored towards their personalised strengths and areas of need. So the purpose of the trial that we did, which was just a 12-month proof of concept trial, was to gather evidence to understand how useful the toolkit is in each of those settings for supporting strengths and needs of autistic and ADHD people. And that's from the perspective of both autistic and ADHD people themselves, but also from the professionals who would receive that information to either inform the services or supports that they then offer or provide, or as part of the diagnostic process. So yeah, just to summarize that this particular part of the study was just to gather information about how useful is this toolkit as a way of opening up support if we were to look at future implementation within the UK. The next step, as Harriet was describing about applying for future funding, and this also follows on from what Sven was saying about how it might be implemented going forward, is our work in partnership with organisations like NHS England and the government to be able to make sure that there is a way of looking at its implementation. There are some systems and infrastructures that we would need to understand as part of the feasibility trial, where we understand what technology limitations are there, what opportunities are there to implement it, and then how can we make sure that we understand what the delivery model looks like for how a toolkit such as this might be rolled out going forward.
I have a question which I think is a very important one. The question is how the results of the ICF toolkit assessment maps against, for instance, mental health and socioeconomic status and other things. And that's also a question that we try to answer while we are doing this large assessment in Sweden. So we're not only collecting 20,000 ICF toolkits assessment, but also we are collecting a lot of data on quality of life and mental and somatic health, and a lot of social demographic kind of data all over Sweden to try to get an idea, for instance, how the different profiles are associated with mental health, with well-being, and if there are differences between, for instance, people who live in certain areas and what kind of help they have received previously, and so forth. So really try to get an understanding of the whole kind of situation and framework. And that's also why we're collecting so many data.
Thanks, Sven, very much for that. So there's a question that came through about the proportion of respondents that were completing the toolkit compared to informant responses. I wanted to invite Harriet to just give a broad description of who was involved. So we presented a slide a little bit earlier on that said all of the different stakeholders that were involved in the study. And the key thing was for us to really gather the insights from both autistic and ADHD people, from family members, because there's people of different ages involved, right, from really young children through to older adults, and then from professionals working with them. So Harriet, I'll just invite you to speak a little bit more to that question.
So for the research that took part this year, which was autistic and ADHD people filling in the toolkit themselves and then giving feedback on the profile, we had 22 people who did that. We then had 16 professionals in each of the different contexts, looking at the profiles and providing feedback on there. So we actually had more community members than we did professionals. For the kind of stakeholder workshops and surveys, we had about 100 responses overall from either participants or from surveys. That split was less so because we didn't actually ask people about their diagnostic status, so it's only if they volunteered that. But I think there were about 25% of people who specifically identified themselves as being autistic and or having ADHD who took part in that. So I hope that answers the question. If it doesn't, please do ask more in the comments.
Thanks very much. I'm going to invite Sven to contribute to this question, and we can add to it from what we've understood in this proof of concept as well. Is there a danger that the toolkit prevents more detailed assessments by sensory trained occupational therapists or speech and language therapists into different areas of need that are more subtle and, when well done, lead to inclusion strategies?
Well, I cannot predict the future, but I think that if we shift our attention well, maybe away from only categorical diagnosis into the more functioning space, I think this will rather help in the future that we do more kind of detailed assessments. And the idea, of course, also is that you can do an ICF assessment as a professional. And as a professional, you will, for scoring ICF, you will, of course, need to do your own assessments to be able to do it. So we are collecting different perspectives. So the standard would be that you mostly do ICF assessments with people who report on themselves, but also kind of people who are close relatives. But of course, there is also in the end the idea that professionals do ratings with the ICF. And for be able to do this, for instance, rating body functions, they need to do their own assessments and then making scores based on their results. So I hope this will not be the case, to the contrary.
Thanks, Sven. And yeah, I'd like to just add to that from the groups that we've worked with. There was really keen involvement from specialist professionals who do more engaged and in-depth work in this area. So it was really important for us that we captured the breadth of professionals who have contact points with autistic people and families at all stages of their life experience, so that we could make sure that if this were to be rolled out in the future, that we have a deeper understanding of where the toolkit will add the most value and where those insights from the profiles would add the most value to be able to open up supports.
There's also another comment I would like to respond to, because it's very important. It's that the questions and items in the toolkit have been experienced as complicated and burdensome, and I absolutely see the point, and we have of course received a lot of feedback around all of this. We have involved as many people as we could, autistic people with ADHD and others, in trying to make those questions somehow understandable and accessible. It is a true challenge. It's probably also something that we need to improve in the future. And I'm also extremely humble when it comes to all of this. But we, in the end, the ICF is also a system that somehow we need to try to operationalize as good as possible. And doing this on this level, we are actually the first people, because it's probably quite a complicated task. But I really see the point, and it's a work in progress. So hopefully we can do things differently. But of course, there's also feedback that questions are not adequate for each and all individuals. Sometimes people think there's not a lot of questions. There are not enough of examples. Others think there are too many examples and too many questions. It's a work in progress, but there's always also the possibility to add comments after each of the items. There's a possibility after each section to try to explain things in your own words. So I hope it gets I hope it is still something that we can use and to make the most bold statement. I think I hope still that it's better to do the ICF questions than doing symptom checklists over and over again.
Thank you, Sven. And actually, just a follow-up from that question was the question about its usefulness or its adaptability for under 18s. And of course, the ICF toolkit is really across the whole lifespan. I wondered if you could speak to some of the insights from your data on younger cohorts.
Yeah, of course. So we have done our development for all ages. It's always easier to get, of course, kind of ratings from older adolescents and adults, but in younger age there is for self-report there's some kind of borderline for the ages. For instance, 8 or 9, you will probably not get a lot of good self-reports be kind of below that age, and there it's mostly parents who are doing the scores, and the scores are rather also more in the body function area and in the activities area. So the items in the course set for very young children, they are kind of a little bit less in the participation area, and a little bit less in the environmental factors area, more in the body functioning area. But yeah, and you get more, and it's more that the ICF is based here on the ratings from parents. But of course, the goal is to have ratings self-report as early as possible, and there is a plan to also generate versions with the toolkit that can be where you can have, for instance, where you can have images to try to explain the items better and give some kind of visual aid, but to also enhance that kind of younger people can do the ratings, and even try to make kind of very easy read questions. But all of this is not trivial. So, for instance, using images that they can also make responding kind of more complicated. So they can maybe make people think that well, something else is inquired about that actually what the item is about. So it's not trivial. But even here, it's something that we are trying to improve. And at the moment, what we have in the system is this accessibility tool that I think also helps some people already to work on the toolkit. But it seems to work well even in younger people. But of course, the younger the group is, the more you all have informant-based data.
Great, thank you so much. There's a few questions that have come through about local authorities being involved, and also action groups, NHS action groups, and automation. So we've been working really closely with NHS England as a consultant on the proof of concept trial. At Autistica, we have strong links to NHS England as well to try and always understand how the work that we do can be brought to life or be implemented in services for autistic people and families. So whilst there aren't any immediate plans for a publicly available date or a date that this is likely to be implemented, that's still very much dependent on us being able to get funding for the feasibility trial, and through that trial understanding what that pathway to implementation looks like. We are working really closely with NHSE to understand how we could do that, and as part of that, having different groups involved for autistic people across the lifespan, including older adults, social workers, wellness action groups, and so forth.
There is another question. So there are questions and answers, but also in the chat. I would like to answer one that's in the chat, and that's how the system is used in Sweden. So even in Sweden, it's still a research instrument, but and they're kind of very different idea about how services would like to use the toolkit, depending on what their kind of what their focus of work is, and kind of which professions are mostly driving these services. So, for instance, in child and adolescent psychiatry, there is child and psychiatry kind of currently also uses as a research tool, while people actually are queuing for assessments. So here the idea is, on one hand, to provide people who are who are waiting for services to provide them with something that can maybe empower them, give them a better picture of their situation, and to provide kind of a summary of their own impressions, so that you at least do something meaningful that maybe gives you new ideas, and also that you have a result that you can bring then later on to your diagnostic assessment. Other clinicians are maybe not so much interested in the ICF profile as such, but would like to have some kind of indication based on the results that can help them to in the pure kind of diagnostic process. If there is really for instance, to make an evaluation of the diagnostic criterion, if there is really if there is a functional impairment that would a kind of present that would qualify for a diagnosis. So so you can both have kind of a pre-diagnostic and post-diagnostic use. So services have different ideas how the system could help them, either kind of before making a diagnosis, during the diagnostic process, or afterwards for trying to develop support actions that with the aim to increase participation and well-being. So it depends, and I assume that's what's the same outcome in the piloting now in the UK.
Thanks very much, and that sort of leads into a question about, you know, whether there were any systemic issues or factors that might make it easier or harder to implement the ICF in some settings than others. It's not a straightforward answer, unfortunately, and this is one of the things that the feasibility trial is will be designed to understand in more detail. We know that just the systems that certain organizations or institutions use, like NHS, for instance, has completely different systems to what schools might use, and they're different again from what employers or some social worker organizations or community organizations might use. So those barriers will be different. But there is also, as Sven was describing earlier, there are, whilst this is still a research tool, when we are thinking about what might be needed for its implementation as a software or something similar in real live day-to-day implementation, there will be all sorts of considerations about the cost of the technology, what training is needed to be able to use that technology, what that means for current workforce as well, particularly in the UK, where we have quite a complex health system of lots of different people being involved, and that's different for children compared to adults and older adults. Those are all things that we need to understand the costs of, but also the opportunities for us to get the right people on board at the right time to make sure that a toolkit such as this is effectively implemented as early as possible.
Because it's also a very important one. There's kind of there's a worry, and it's not the first time I hear it, that that actually kind of using the ICF or the toolkit, that it could be misused for kind of denying people access to services, not kind of saving money rather than actually improving services. That's of course an absolutely legitimate kind of worry to have, which I also share. So there, when I have contact with services or also with insurance companies, there's often another kind of another idea how they would try to use it, at least maybe not necessarily for saving money, but kind of but trying to allocate the resources that there are in a more effective way, and to be more sure about the decisions that they take. But of course, there's absolutely, unfortunately, no way currently to prevent that things that are out there that with the intention to improve services that they get misused. That is something that is really about the ethics and the procedures of the people who are using it, and the authorities and care providers, how they use it. I think it's probably uncontrollable, but the question is if they should refrain us from doing things that go still in the right direction. And I think each and every one who uses it and is familiar with the ICF has actually an own role in trying to guarantee that it's used in the correct way, and try to be an ambassador for using it for improving things and not for making things worse.
Thank you very much, Sven. And thank you so much for all of the comments and the questions coming through on both the chat and the Q&A. We've only got time for one more question. The question that's come in is about how the ICF might be adapted to other neurodevelopmental conditions. And Sven, as the topic expert on this, I wanted to invite your input to this question.
Sure. So there are two answers to this. So the first is there's one official way to do core sets, which is the basis for doing this toolkit, and this is doing it together in collaboration with the WHO. So that gets an official process, which we have done, and the WHO makes a decision if they want to do a collaboration around certain core sets that serve certain diagnostic areas. So if people want to have an official process, they need to apply to the WHO. They need to ensure that they have resources, that they have the competence, that they have a plan to do official process with the WHO, which we have chosen to do just to give the whole thing a good deal of authority and strength and kind of muscles, and really that people think this is well kind of it's a work that you can have trust in. So but on the other hand, everyone is completely free in using a very similar kind of process and pipeline as the WHO uses to generate own core sets, and to try to adapt them to their environments for other diagnoses. There's a set of core sets for the neurodevelopmental and mental health sector. So they're also in the area of neurodevelopmental conditions. There's only autism and ADHD, but in the mental health sector, there's also depression and schizophrenia and bipolar, and they're related core sets, for instance, for cerebral palsy and for sleeping disorders. But there's nothing for instance for dyslexia or Tourette's or other neurodevelopmental conditions. But people are free, especially researchers and clinicians, to do their own core sets and try to make sense of this. What we are planning is we are planning to try to integrate the existing core sets that have been generated with the help of the WHO researchers, those existing core sets that have this official authority by WHO, trying to implement all of those on this platform. So also trying to implement those for instance, depression and cerebral palsy and sleeping disorders on this platform in the future. So that's our plan.
Wonderful. Thank you so much, Sven. And again, thank you so much for all of the questions and comments. Unfortunately, we've not been able to get through to all of them today because there was just so many. And so a huge thank you from me for your really high engagement and your interest in this topic. There's a few people who've commented on their involvement in the project as well, through their comments and chats. And thank you so much to our autistic advisors who really helped to shape this proof of concept and helped us to get underneath some of the core issues that would better understand how the toolkit can be used in day-to-day life to support the needs and areas of strength to empower autistic people to live happy, healthy and long lives, and to also understand how this can be useful across the person's lifespan. So at this point, we'll bring the session to a close, but we really invite you to keep in contact with us to see how this project continues to develop. We'll keep sharing information across the Autistica network and through our newsletters. So please do sign up to the newsletter if you've not already, or come back to our website and see how the project is progressing. And we hope to be able to share some more information with you very soon. I'd also like to thank Harriet for presenting the findings from this study and for leading this incredible project over the last 12 months. And our sincere gratitude to Sven as well, who's been our guide along the way and who's much further along the journey in understanding the nuances of the toolkit and bringing it to life. And thank you for joining the session, to Sven and to each of you who've contributed to this discussion today. Take care, everybody. Bye-bye.